Endocrinology minutes with cyan. Pituitary. The adult pituitary weighs approximately 600 milligrams and measures approximately 30 millimeters in the longest transverse diameter. During pregnancy, the pituitary weight increases up to 1 gram. There are three hypothalamic pituitary target organ axes. The hypothalamic pituitary adrenal axis is the pivotal system subserving stress and survival, elaborated through effects on the energy supply, fuel metabolism, immunity, and cardiovascular function. The hypothalamic pituitary gonadal axis plays a pivotal role in puberty, reproductive function, and fertility, controlling both gametogenesis and sex steroid hormone production. The hypothalamic pituitary thyroid axis plays a critical role in development, growth, and cellular metabolism mediated by thyroid hormones. The posterior pituitary gland is directly innervated by the supraoptical hypophyseal and the tuberal hypophyseal nerve tracts of the posterior stalk. Hypothalamic neural lesions often cause attenuated vasopressin or oxytocin secretion. In contrast to those in the posterior pituitary, 5 distinctive hormone-secreting cell types are present in the mature anterior pituitary gland. Each cell type is under highly specific signal controls that regulate their respective differentiated gene expression. Cortical trough cells express pro-opiomelanocortin peptides including adrenocorticotropic hormone. Somatotroph cells express growth hormone. Thyrotroph cells express the common glycoprotein alpha subunit and the specific thyroid-stimulating hormone beta subunit. Gonadotroph cells express the alpha and beta subunits for both follicle-stimulating hormone and luteinizing hormone. Lactotroph cells express prolactin. Lower part of the figure amplifies the tumor formation for each pituitary cell type. All patients harboring hypothalamic or pituitary masses should be screened for hypopituitarism. Treatment of pituitary failure mainly embraces replacement therapy of 6 pituitary tropic hormones and the vasopressin. Next part will focus on the physiology and disorders of pituitary hormone axes and the 6 pituitary tropic hormones. The structure, transcriptional regulation, and measurements are omitted. We try to put the emphasis on the clinical features and therapy. Prolactin. The highest level of prolactin is achieved during sleep and the lowest occurring between 10 a.m. and noon. Prolactin levels and pulse frequency decline with age in both men and women. A gain-of-function mutation conferring constitutive activity of the prolactin receptor is present in a subset of patients with multiple breast fibroadenomas. Prolactin receptor antagonists have been developed to resist prolactinomas, breast tumors, and prostate tumors. Of course, prolactin mainly functions in control of puberty and reproductive system. Interesting to mention that prolactin has been shown to have immune function. It has protective effects against inflammation-induced chondrocyte apoptosis with potential to reduce joint damage and inflammation in rheumatoid arthritis. Galactorrhea and reproductive dysfunction are the hallmarks of pathologic hyperprolactinemia. Women present with galactorrhea associate with a range of menstrual disturbances including infertility, oligomenorrhea, and amenorrhea, and men present with symptoms of hypogonadism and of tumor mass effects with galactorrhea occurring infrequently. The only known clinical manifestations of prolactin deficiency is the inability to lactate after delivery. Isolated prolactin deficiency has been reported in association with autoantibodies directed specifically against prolactin-secreting pituitary cells. Recombinant human prolactin administration for women with prolactin deficiency or lactation insufficiency is under investigation. Growth hormone. Up to 70% of daily growth hormone secretion occur with the first episode of slow-wave sleep. Growth hormone concentration is high in the fetal circulation, peaking during mid-gestation. Neonatal levels are low and stable during childhood, rises at the onset of puberty. Growth hormone functions as a major metabolic hormone in the adult by optimizing body composition and physical function as well as regulating energy and substrate metabolism. Metabolic actions of growth hormone also closely interact with those of insulin in the control of fat, glucose, and protein metabolism during fasted and fed states. Life expectancy is reduced in hypopituitary patients with growth hormone deficiency largely as a consequence of cardiovascular and cerebrovascular events, especially in female subjects. As to precautions, patients with active malignancies should not be treated with growth hormone. Studies have reported association between higher normal IGF-1 levels and later risk of developing prostate cancer, breast cancer in premenopausal women, and colon and lung cancer. In contrast, patients with acromegaly do not have an increased incidence of either breast or prostate cancer or cancer in general. Investigational uses of growth hormone include catabolic states, osteoporosis, human immunodeficiency virus infection, sports, and aging. The anabolic actions of growth hormone have been used in catabolic states include surgery, trauma, burns, parenteral nutrition, and organ failure. Growth hormone is Food and Drug Administration approved for administration to adult patients with human immunodeficiency virus-associated cachexia and results in positive nitrogen balance, increased lean body mass, decreased body fat, and improved work output. The public policy issues of growth hormone abuse in competitive sports has received much attention. Growth hormone enhances anaerobic sprint capacity but not aerobic capacity, strength, or power in recreational athletes. Growth hormone as anti-aging therapy is not approved by the FDA in the United States. Adrenocorticotropic hormone. Pro-opiomelanocortin is expressed only in corticotroph cells. The pro-opiomelanocortin gene products including ACTH, beta-lipotropin, and endorphins. Ectopic ACTH synthesis means inappropriate ACTH processing. It can happen in the gonads, lung, skin, gastrointestinal, and adrenal medullary neuroendocrine cells and white blood cells. These patients also exhibit a higher ratio of circulating ACTH precursors as well as small peptides. The manifestations of ACTH deficiency are clinically indistinguishable from glucocorticoid deficiency of any cause. In the newborn, ACTH deficiency may present as hypoglycemia and failure to thrive. In the adult, there is slowly progressive weight and appetite loss, anorexia, and generalized fatigue mimicking a wasting syndrome. On the other hand, excessive ACTH production can arise from a corticotroph adenoma or from an extrapituitary ectopic tumor source. Small cell lung carcinomas, bronchial carcinoids, and neuroendocrine tumors are common causes of ectopic ACTH production. ACTH induces adrenal hyperfunction, causes a syndrome of hypercortisolism called Cushing disease, and it also induces androgen excess in women. Adrenal steroid replacement. Hydrocortisone is widely used for glucocorticoid replacement. Dual-release hydrocortisone tablet containing an immediate-release coating and an extended-release core was approved by the European Medicines Agency for once-daily therapy of adrenal insufficiency in 2012. The modified-release preparation mimics cortisone diurnal profiles and exhibited improved weight, glucose, and blood pressure control compared to conventional thrice-daily hydrocortisone dosing at the same total daily dose. Gonadotropins. Gonadotroph cells secrete follicle-stimulating hormone and luteinizing hormone, which are critical in the reproductive development, puberty, and fertility. Gonadosteroid hormones include estrogens, progesterones, and androgens. As to the clinical features, gonadotropin deficiency causes hypogonadism with decreased sex steroid production. Hypothalamic and pituitary disorders are the most common endocrine cause of male subfertility. Mutations that abolish the activity of luteinizing hormone, resulting in isolated luteinizing hormone deficiency, has also been reported. In males, they may manifest with delayed or absent puberty as a result of low testosterone levels. A female with isolated luteinizing hormone deficiency had normal pubertal development and menarche, but secondary amenorrhea and infertility. Continuation should be determined on an individual basis by assessing risk and benefits, especially in terms of bone mineral integrity, cardiovascular function, and cancer risk. Estrogen treatment may be associated with thromboembolic disease, breast tenderness, and possibly enhanced risk for breast cancer. For men, androgen replacement is available as intramuscular gel, patch, or oral preparations. Testosterone replacement should not be administered to men with diagnosed prostate cancer. Thyroid stimulating hormone measurement is not helpful in diagnosing central hypothyroidism, which is identified by concurrent measurement of thyroid hormone levels. The consequences of thyroid stimulating hormone deficiency are those of thyroid hormone deficiency, which causes childhood mental and growth retardation, and in adults is associated with a broad spectrum of clinical features, including hypothermia, fluid retention, voice and skin change, and ultimately, if untreated, frank myxedema and death. Levothyroxine is used for replacement therapy, but T4 overdosing may lead to bone demineralization and cardiac arrhythmias. Thanks for watching. If you enjoyed this video, just replay it. If you have any questions or suggestions, feel free to contact me through email. If there is the next episode, see you then!